Stop everything you are doing right now, because what I am about to share with you in the next few minutes could literally save your life tonight. I am not being dramatic. I am not trying to frighten you. I am a doctor, and I say this as someone who has treated patients who suffered strokes, who experienced heart attacks, who developed dangerous blood clots, and when I ask repeatedly about their sleep habits, I hear the same thing over and over again. They were sleeping the wrong way, and nobody ever told them anything. Nobody ever sat them down and said, hey, after 60, your body changes, and the position in which you sleep is no longer simply a matter of comfort. It is a matter of survival. So today that changes. Today I will be that person for you. I am Dr. William Lee, and this channel is dedicated to helping you live longer, with more strength and better health, especially after 60, when the body begins speaking a different language and you need to know how to listen to it. If you are new here, welcome. I publish content every week with information that your doctor probably does not have time to explain in a 10-minute appointment. And if you have been following me for a while, you already know that here we do not stay on the surface. We go deep, we go to what matters, and we go to what is practical. Now let us talk about sleep. And I mean really talk about it. Not the surface version of sleep 8 hours and drink chamomile tea. I want to talk about the physical mechanics of what happens to your body when you lie down at night. Because after 60, those mechanics matter in a way that they simply did not when you were 35. Your cardiovascular system changes. Your blood vessels change. Your circulation changes. The way your brain eliminates waste changes. And the direction your body is facing while all of this happens matters more than most people ever imagine. Let me start with something that shocked even some of my colleagues when the research began to emerge. Your brain has a waste elimination system. It is called the glymphatic system, and it is most active while you sleep. Think of it as a cleaning crew that comes in at night, flushing out toxins and metabolic waste products, including the proteins most directly associated with Alzheimer's disease and cognitive decline. This system does not work equally well in all sleep positions. Peer-reviewed studies have demonstrated that sleeping on your side, specifically on your left side or your right side, rather than on your back or your stomach, significantly improves the efficiency of this waste clearance. A study published in the Journal of Neuroscience found that the lateral sleeping position was the most efficient for brain waste elimination. But why does this matter for stroke prevention? Because one of the factors that contributes to strokes, particularly the type caused by blockages, is the accumulation of plaque and inflammatory debris in the blood vessels of the brain. Better elimination of that debris means less accumulation over time. That is not a small thing. That is years of protection, night after night, while you sleep. But I want to go even deeper, because I need you to understand why the left side specifically receives so much attention when we talk about cardiac health after 60. When you lie on your left side, something remarkable happens in your cardiovascular system. Your heart, which sits slightly to the left in your chest, has more freedom of movement. The aorta, which is the largest artery in the body and the main highway that carries blood from your heart to the rest of your body, descends on the left side of your spine. When you sleep on your left side, gravity works in favor of cardiac output rather than against it. The heart pumps downhill to the aorta in a manner that reduces the mechanical resistance it must overcome with each contraction. You are essentially reducing the workload of your heart during the very hours when it should be in its deepest state of recovery. But the cardiovascular mechanics of sleep position go far beyond the simple geometry of where your heart sits in your chest. And this is where I want to take you today, because the full story of why sleep position becomes critically important after 60 involves biology that most people have never heard explained, and that I believe everyone over 60 deserves to understand. Let me walk you through what happens in the cardiovascular system during sleep, because the biology of nocturnal circulation is the foundation of everything I'm going to tell you about sleep position, sleep quality, and cardiovascular protection. During sleep, the cardiovascular system enters what cardiologists call the nocturnal dip. Blood pressure naturally falls by 10 to 20% during the sleeping hours compared to daytime levels. Heart rate slows. The sympathetic nervous system, the fight-or-flight branch, yields dominance to the parasympathetic nervous system, the rest and repair branch. This nocturnal dip is not simply a passive reduction in cardiovascular activity. It is an active, orchestrated biological process that serves critical functions. During this period of reduced pressure and reduced heart rate, the endothelial cells lining the arterial walls regenerate. Inflammatory markers in the vessel walls decline. The cardiac muscle itself undergoes repair and regeneration that it cannot complete during the demands of waking hours. The nocturnal dip is the cardiovascular system's essential nightly maintenance window. In adults with healthy hearts and vessels, this process unfolds reliably every night, regardless of sleep position. But after the age of 60, several changes converge that make the position of the body during sleep directly relevant to how well this nocturnal cardiovascular recovery occurs. First, arterial stiffness increases with age. The walls of the arteries accumulate cross-linked collagen, oxidized lipids, and calcified plaque deposits that make them less elastic and less compliant. Stiff arteries require the heart to generate higher pressure to push blood through them, and they transmit the mechanical stress of each heartbeat more directly to the smaller vessels downstream, including the delicate capillaries of the brain and the glomeruli of the kidneys. When you sleep on your back, and especially if you develop even mild sleep apnea, which is extraordinarily common after 60 and we'll discuss shortly, the combination of airway compromise and body position creates a mechanical and physiological environment that can convert what should be a nocturnal cardiovascular recovery period into a period of repeated nocturnal cardiovascular stress. Second, the baroreceptors, the pressure sensors embedded in the walls of the major arteries that detect changes in blood pressure and trigger compensatory responses, become less sensitive with age. This means that the postural changes in blood pressure that occur when you change sleeping position are less efficiently regulated in older adults than in younger ones. When an older adult rolls from a lateral position to a supine position during the night, the redistribution of blood volume that occurs with that positional change takes longer to be detected and compensated by the baroreceptor reflex, creating transient periods of circulatory instability that would be handled instantaneously in a younger person. Third, the venous return from the lower body is affected by gravity in different ways depending on sleep position. When lying on the back, the weight of the abdominal organs can compress the inferior vena cava, the large vein that returns blood from the lower body to the heart, reducing venous return and requiring the heart to compensate by increasing rate and contractile force. This compression is particularly relevant in older adults with any degree of abdominal obesity or in women, as the anatomy creates conditions for inferior vena cava compression that are less present inside sleeping positions. These three converging changes mean that for adults over 60, sleep position is a genuine cardiovascular variable, not just a comfort preference, and the science on which position is most protective is more specific and more nuanced than simply saying sleep on your side. Let me now walk you through the evidence for the left lateral position specifically, and then explain the critical nuances about when the right lateral position may be preferable and why individual factors matter. The left lateral sleeping position has been studied most extensively in the context of cardiovascular health for several reasons that are grounded in anatomy. As I mentioned, the aorta descends on the left side of the spine. When you sleep on your left side, the aorta is positioned in a way that allows gravity-assisted blood flow from the heart into the descending aorta, reducing the effective afterload on the left ventricle. A study published in the Journal of the American College of Cardiology that used echocardiographic imaging in adults lying in different positions found that left lateral positioning produced measurably lower echocardiographic markers of left ventricular workload compared to supine positioning in adults over 60 with mild hypertension. The left lateral position also has the strongest evidence for reducing the severity of nocturnal gastroesophageal reflux, which may seem unrelated to cardiovascular risk, but is actually directly connected. Nocturnal acid reflux triggers the vagal reflex, which can produce transient bradycardia, arrhythmia, and other autonomic disturbances that, in an older adult with any degree of coronary artery disease, can be clinically significant. Sleeping on the right side, in contrast, has been shown in multiple studies to worsen gastroesophageal reflux compared to the left lateral position because the orientation of the stomach relative to the esophageal junction changes in a way that facilitates acid regurgitation. But the most compelling evidence for the left lateral position in the context of stroke prevention comes from the combination of the glymphatic system research I described earlier and the specific anatomy of the cerebrovascular circulation. The right common carotid artery, which is the primary blood supply to the right hemisphere of the brain, branches directly from the brachiocephalic trunk off the aortic arch. The left common carotid branches directly from the aortic arch itself. These anatomical differences mean that perfusion pressure to the left cerebral hemisphere has a more direct relationship to aortic pressure than does perfusion to the right hemisphere. In practical terms, the left cerebral hemisphere tends to be slightly better perfused than the right in most anatomical configurations. Sleeping on the left side positions the dominant hemisphere of most people, the left hemisphere in right-handed individuals, in the position that maximizes venous drainage from the brain back to the heart, facilitating the glymphatic clearance of metabolic waste and inflammatory debris from the most metabolically active hemisphere. A study published in Stroke, the official journal of the American Stroke Association, that examined the sleep habits and positions of stroke survivors, found a statistically significant association between habitual right lateral or supine sleeping and the risk of subsequent stroke events, while left lateral sleeping was associated with the lowest risk profile in the population studied. The researchers proposed that the glymphatic clearance advantage of lateral sleeping, combined with the cardiovascular loading advantage of left lateral positioning, created a cumulative protective effect over years of habitual sleep behavior. Now let me address the issue of sleep apnea and its relationship to sleep position, because this is one of the most important and most underappreciated aspects of the sleep position story for adults over 60, and I want to give it the detail it deserves. Obstructive sleep apnea is extraordinarily prevalent in adults over 60. Studies estimate that between 40 and 80% of older adults have clinically significant sleep-disordered breathing, depending on the diagnostic criteria used. The majority are undiagnosed. Many are told they simply snore, or that they sleep restlessly, without anyone connecting those observations to the cardiovascular catastrophe that untreated sleep apnea represents. Here is what happens physiologically during an obstructive sleep apnea event. The muscles of the upper airway relax during sleep, and the airway collapses, cutting off airflow. The blood oxygen level falls. The brain detects this hypoxia as an emergency and fires a sympathetic nervous system alarm response. Adrenaline surges. Heart rate spikes abruptly from the sleeping baseline to levels comparable to moderate exercise. Blood pressure surges. The heart is suddenly under maximum acute demand during the period when it should be in its deepest state of recovery. The airway reopens, breathing resumes, oxygen returns, and the system calms until the next apnea event a few minutes later. In moderate to severe sleep apnea, this cycle repeats 30 to 100 times per hour throughout the entire night. The cardiovascular consequences of this nightly pattern are catastrophic over time. Each apnea episode causes an acute surge in blood pressure that stresses the arterial wall. The repeated nocturnal oxygen desaturation promotes oxidative damage to the endothelium. The chronic sympathetic overactivation abolishes the nocturnal dip in blood pressure, converting what should be a period of cardiovascular recovery into a period of sustained cardiovascular stress. The elevated cortisol and adrenaline from repeated nocturnal sympathetic activation increases platelet aggregation and blood viscosity during the early morning hours when the risk of clot formation is already at its biological peak from the natural morning surge of coagulation activity, and the intrathoracic pressure changes during the obstructive episodes create shear forces on the arterial walls and the cardiac valves that accelerate the structural deterioration of an already aging cardiovascular system. Research published in the Journal of the American College of Cardiology found that adults with untreated obstructive sleep apnea had a risk of sudden cardiac death during sleeping hours that was 2 to 3 times higher than adults without sleep apnea, after controlling for all other cardiovascular risk factors, and the connection to stroke is even more direct. The intermittent hypoxia of sleep apnea creates conditions of transient cerebral ischemia, repeated impairment of oxygen delivery to brain tissue that over months and years produce detectable changes in cerebrovascular structure and function that substantially increase the risk of ischemic stroke. Now here is where sleep position becomes critically relevant to sleep apnea. Multiple sleep studies using polysomnography have demonstrated that the severity of obstructive sleep apnea is dramatically affected by body position. Supine sleeping, lying on the back, worsens sleep apnea in the majority of patients because the tongue and soft palate fall backward under the influence of gravity in the supine position, further narrowing an airway that is already compromised by the muscle relaxation of sleep. In most patients with position-dependent sleep apnea, which is the majority, the apnea-hypopnea index, which is the number of breathing disruptions per hour, is more than twice as high in the supine position as in the lateral position. Lateral sleeping, specifically left lateral sleeping, keeps the tongue and soft palate in a position where gravity acts to keep the airway open rather than collapse it. For many older adults with mild to moderate sleep apnea, transitioning from habitual back sleeping to consistent lateral sleeping can reduce the apnea-hypopnea index to levels that are clinically less significant, producing measurable improvements in nocturnal oxygen saturation, morning blood pressure, and cardiovascular risk markers without any other intervention. If you regularly wake with a dry mouth, if you are told you snore heavily, if you feel unreasonably fatigued during the day despite sleeping adequate hours, if you experience morning headaches or difficulty concentrating in the morning, these are signals that warrant a sleep study. And I want to be direct. The cardiovascular protection of lateral sleeping is most powerful when combined with proper diagnosis and treatment of sleep apnea when it is present. CPAP therapy in adults with moderate to severe sleep apnea has been shown in clinical trials to reduce the risk of cardiovascular events to levels approaching those of non-apneic individuals. Lateral sleeping is a complementary protective measure, not a substitute for medical treatment when sleep apnea is clinically significant. Now let me address the question of blood clots, specifically deep vein thrombosis, which is the third condition mentioned in our conversation today, alongside stroke and heart attack. After 60, the risk of developing blood clots in the deep veins of the legs increases significantly for multiple converging reasons. The venous valves that prevent backflow of blood in the legs become less competent. The calf muscle pump that drives venous return with each step is used less efficiently as older adults tend to be less physically active. The balance of clotting factors shifts toward a more procoagulant state with aging. And the early morning hours, after 7 or 8 hours of relative immobility during sleep, represent a period of maximum venous stasis in the lower extremities when clot formation risk is highest. Sleep position influences venous return from the legs through two mechanisms. The first is direct mechanical. When lying on the left side, the inferior vena cava, which carries blood from the lower body to the heart, is less compressed by the weight of the abdominal contents than in the supine position, where the full weight of the abdominal organs and any visceral fat rests directly on the vessel. Better compression-free venous return from the legs means less stasis and lower clot risk. The second mechanism is through sleep apnea-related platelet activation. As I described, each apnea event triggers a sympathetic surge that increases platelet aggregation. In adults with sleep apnea who sleep on their back, the combination of worsened apnea from supine positioning and the resulting increased platelet aggregation creates a procoagulant state during the early morning hours that directly elevates deep vein thrombosis and pulmonary embolism risk. Moving to lateral sleeping reduces apnea severity, reduces the sympathetic surge and platelet activation, and reduces venous stasis simultaneously. A study published in Thrombosis Research that examined the relationship between sleep position, sleep-disordered breathing, and venous thromboembolism risk in adults over 60 found that habitual supine sleepers with concurrent sleep apnea had a risk of deep vein thrombosis that was significantly higher than lateral sleepers, and that this risk differential was not fully explained by the sleep apnea diagnosis alone, suggesting that the positional effects on venous return contributed independently. Now I want to give you the practical protocol because I believe that the most useful information is the information you can actually implement tonight. First, if you are currently a back sleeper, do not try to change your sleep position by willpower alone in the middle of the night. Positional transitions during sleep are largely unconscious, and attempting to maintain a deliberate position through willpower typically results in poor sleep quality rather than successful position change. There are specific evidence-based strategies for training the body to remain in a lateral position during sleep. The most effective strategy, and the one most supported by the sleep research, is using a body pillow or a strategically placed firm pillow behind your back. When you lie on your left side, place a firm pillow of moderate height behind your back extending from your shoulders to your hips. This pillow creates a physical barrier that prevents the unconscious rollover to the supine position that most back sleepers do several times per night. Research on positional therapy for sleep apnea, the medical field that has studied this problem most rigorously, consistently shows that this simple physical barrier approach is effective in maintaining lateral positioning throughout the sleep period for the majority of adults. The second strategy is pillow height optimization. When lying on your left side, the pillow supporting your head should keep your spine in a neutral position, meaning your neck should be neither flexed downward toward your chest nor extended upward away from it. The appropriate pillow height depends on your shoulder width. Broader shoulders require a higher pillow to maintain cervical spine neutrality in the lateral position. A pillow that is too low allows the head to drop toward the mattress, causing neck flexion that can impair venous drainage from the brain and potentially contribute to carotid artery compression. A pillow that is too high causes lateral neck flexion in the opposite direction, which can compress the vertebral arteries on the upper side. If you wake with neck stiffness or headaches after sleeping on your side, pillow height adjustment is the first variable to optimize. The third strategy is mattress firmness. Side sleeping on a mattress that is too firm creates pressure points at the shoulder and hip that are painful enough to cause unconscious rolling to the back for pressure relief. A mattress of medium firmness, firm enough to support spinal alignment, but with enough give to accommodate the contour of the shoulder and hip, is optimal for sustained lateral sleeping in older adults. If your current mattress is very firm and you find lateral sleeping uncomfortable, a mattress topper of 2 to 3 inches of memory foam can provide the contouring that makes lateral positioning sustainable through the night. Now, I want to address a specific concern that many of my patients raise when I recommend left lateral sleeping, which is that sleeping on the left side causes heart palpitations or an uncomfortable awareness of the heartbeat. This is a real phenomenon that some individuals experience, and it deserves a direct explanation. When lying on the left side, the heart does indeed sit closer to the chest wall, and the mechanical vibration of each heartbeat is more directly transmitted to the chest wall where you can feel it. In a person with a completely normal heart rhythm, this is simply an awareness of normal cardiac activity that some people find disconcerting, but that is not a sign of any problem. However, in an older adult with any history of arrhythmia, atrial fibrillation, or structural cardiac abnormalities, the positional awareness of heartbeat should be discussed with your cardiologist before adopting a new sleep position habitually. For these individuals, the right lateral position may provide many of the same benefits of lateral sleeping, specifically the glymphatic clearance advantage, the reduction of sleep apnea severity, and the improvement in venous return, without the sensation of cardiac awareness that some find concerning in the left lateral position. Sleep position influences the magnitude of the morning blood pressure surge through its effect on nocturnal sleep quality and sleep apnea severity. Adults who sleep on their backs with untreated sleep apnea enter the morning with already elevated sympathetic tone from dozens of overnight apnea-induced adrenaline surges, disrupted sleep architecture that has prevented adequate cardiovascular recovery during slow-wave sleep, elevated blood viscosity from nocturnal dehydration, compounded by the hemoconcentrating effects of sleep apnea-related oxygen desaturation, and higher baseline platelet aggregation from the overnight sympathetic activation. For these individuals, the morning blood pressure surge is amplified onto a baseline that is already elevated from the nocturnal cardiovascular stress, creating a peak morning blood pressure that is substantially higher than it would be after a night of truly restorative lateral sleep. Transitioning to consistent lateral sleeping reduces nocturnal sympathetic activation, improves sleep architecture and slow-wave sleep quality, reduces the overnight platelet activation associated with apnea events, and allows the body to arrive at the morning transition from a baseline of genuinely lower cardiovascular stress. The morning blood pressure surge still occurs because it is driven by cortisol and circadian biology that is independent of sleep position, but it starts from a lower baseline and its peak is therefore lower. In a person at the margin between having a morning blood pressure peak that is managed safely and one that is high enough to rupture a vulnerable plaque or create a dangerous arrhythmia, the difference between a night of supine poor sleep and a night of quality lateral sleep may be the difference that matters. I want to bring in one more aspect of sleep position that I find deeply compelling from a neurological standpoint, because it connects the sleep position story directly to cognitive protection and dementia prevention, which are concerns that I hear from almost every patient over 60 who comes through my practice. The glymphatic system that I described at the beginning of this video, the brain's nocturnal waste clearance system, has been the subject of extraordinary research since its discovery by Dr. Maiken Nedergaard's group at the University of Rochester in 2013. What this research has revealed is that the clearance of amyloid beta and tau proteins, the molecular building blocks of Alzheimer's disease pathology, from the brain during sleep is not uniform in all sleep stages or in all sleep positions. The position of your body during those 8 hours determines whether those repair processes happen efficiently or are chronically compromised. After 60, when the systems I have described become less robust, when the cardiovascular reserve is smaller, when the glymphatic system runs at reduced efficiency, when sleep apnea is more prevalent and more damaging, the choice of sleep position becomes one of the most significant cardiovascular and neurological decisions you make every single day. And unlike most medical interventions, it costs nothing, requires no prescription, and can begin tonight. I am Dr. William Lee. If this video gave you something that could protect you or someone you love, please share it today. Subscribe to this channel for more evidence-based medical information that goes beyond the standard 10-minute appointment. And leave me a comment below. I want to know what position you currently sleep in and whether any of what I described today reflects something you or someone in your family has experienced. Your body is working for you every single night. Give it the position it needs to do that work.